Can food help survivors heal? It seems like a basic question, but to truly answer it, we need to think through what that means. Is it the food? Is it the preparation method? Or is it something deeper and more complex? It all has to do with something called trauma-informed care. Put simply, this is a collaborative approach taken together by a variety of professionals, emphasizing safety, trust, collaboration, and patient empowerment. It is as much a mental health approach as it is a physiological one. But how is that relevant to nutrition? An increasingly common treatment for certain mental health conditions like anxiety, depression, and PTSD is MNT, or medical nutrition therapy. Medical nutrition therapy is a type of nutrition-based intervention typically used for physiological conditions like preventing heart disease or kidney failure from worsening, but there is increasing evidence suggesting that MNT could also be used for treating symptoms of anxiety and depression. But what context is this intervention appropriate for, and who can really benefit from it the most? Well, there are many cases of mental health disorders, particularly in children who are at greater risk of developing mental health disorders and disordered eating habits, where trauma-informed care has proven great success, especially when coupled with early intervention following precipitating incidents. One catastrophic yet common cause is childhood sexual abuse, which simply put is any sexual activity with a child by an adult, adolescent, or older child. The effects of this trauma and abuse are widespread, and so often have lasting and harmful impacts on victims. Therefore, a new approach is needed to reduce these dangerous manifestations of trauma, that is, the symptoms associated with the abuse. Thinking beyond the typical mental health consequences like anxiety and panic disorders, feelings of safety in potentially all environments can be greatly impacted. Furthermore, depression is extraordinarily common and tragically associated with self-harm and suicidal ideation, so much so that experiencing any amount of childhood sexual abuse is associated with a significant increase in both acute and lifelong suicide risk. There is certainly a need, then, for proactive support in these cases. It is vital to get ahead of the problem if it occurs. Symptoms often go unnoticed, even by close friends, coaches, and teachers. Failed recognition or recognition delay often interferes with intervention in children until obvious, debilitating physical and psychological consequences have already become severe. Unfortunately, little attention is given to some of the more hidden conditions that have a direct overlap with physiology. Importantly, though also rarely acknowledged, all of these mental health conditions greatly contribute to disordered eating habits in many cases. These patterns can quietly reshape a survivor's relationship with their own body long before anyone realizes something is wrong. Eating disorders pose a unique threat for survivors, as they not only prevent healing in and of itself, but they are a destructive manifestation of trauma that blurs the line between emotional pain and physical harm. These eating patterns are not incidental outcomes. They are physiological adaptations to overwhelming stress. Trauma alters cortisol rhythms, disrupts the gut microbiome, and changes how hunger is interpreted. Chronic stress alone is enough to fragment digestive processes and appetite regulation, but what starts as a survival response gradually becomes a pattern physiology. A muted hunger cue here, a stress-induced binge there, and days where food feels irrelevant, and days where it becomes the only controllable variable. Survivors learn to navigate their bodies in terms of protection, not nourishment. So if trauma reshapes internal regulation, then healing has to involve restoring that regulation, slowly, collaboratively, and without replicating any dynamics of coercion. In this way, nutrition becomes not just an add-on, but a critical part of trauma response. Integrating medical nutrition therapy into a trauma-informed approach creates a pathway to address both the psychological and physiological consequences of childhood sexual abuse. This integration recognizes that trauma does not just harm the mind, it dysregulates the body, influencing self-image, metabolism, gut health, and long-term disease risk. MNT helps bridge this gap by supporting the survivor's internal systems, helping them rebuild patterns of nourishment, safety, and autonomy. But to see how MNT can become a restorative practice, we need to zoom out and look at how entire communities heal after violations of sovereignty, and how food plays a role in that restoration. Indigenous feminist thinkers, especially Winona LaDuke, offer a framework that repositions food as a site of identity, autonomy, and healing. LaDuke argues that colonization did not only take land, it disrupted food systems, severed relationships with nourishment, and replaced autonomy with externally imposed control. The result was not just hunger, but disorientation, a loss of rhythm, balance, and regulation. The structure mirrors trauma at the level of the individual. Child sexual abuse is to bodily sovereignty what colonization is to cultural sovereignty. Both are intrusions, Both impose dominance, both fracture systems that once offered safety and continuity, and neither injury heals through mere treatment, both require restoration. Decolonizing food systems involves returning control, meaning, and connection to communities. Trauma-informed MNT mirrors this by returning bodily agency, internal trust, and physiological coherence to survivors. LeDuc's emphasis on food as relationship, to land, history, community, and self, translates directly into trauma-informed care. Survivors of CSA also need restoration of relationship, with hunger cues, with bodily signals, the act of eating, and ultimately, themselves. MNT becomes part of that reclamation, not a directive, but a practice of reestablishing connection. Not a meal plan or a diet, but an invitation to inhabit the body with increasing safety. In both indigenous food sovereignty and trauma-informed MNT, the point is not control, it is the rebuilding of autonomy. In practice, trauma-informed MNT shifts the role of the clinician from authority to collaborator. Survivors are not told what to eat, they are supported in understanding why their eating patterns developed as they did, and how those patterns can be gently reshaped. This may involve stabilizing mealtime routines, identifying fear-based food responses, restoring connection to hunger and fullness, reducing shame and hypervigilance around digestion, and preventing malnutrition through personalized nutrition care. The approach is grounded in consistency, predictability, and the avoidance of re-traumatization, because care should never reproduce the dynamics of the harm it seeks to address. Over time, the survivor's practices existing in their body with less alarm and more clarity, rebuilding internal cues that trauma once disrupted. Even the most promising treatment models remain inaccessible without structural support. As it stands, insurance reimbursement for MNT narrowly applies to conditions like diabetes and kidney disease. Trauma-related dysregulation, disordered eating, and physiological consequences of CSA fall outside these categories, despite strong evidence linking trauma to long-term metabolic and mental health risks. This leaves survivors without access to interventions that could prevent chronic complications and reduce reliance on later crisis care. Policy must evolve, then, to recognize trauma as a condition with legitimate nutritional needs, expand coverage of psychological treatment plans, fund trauma-informed care teams, support community-based food programs as public health interventions, and treat nutrition as preventive care rather than a luxury. Without these measures, survivors only receive fragments of the care that they need. So, can food help survivors heal? Not alone, but as part of a trauma-informed, culturally grounded, interdisciplinary approach, food becomes far more than sustenance. It becomes a stabilizing practice, something predictable in a body that trauma has made unpredictable. It becomes an anchor for self-regulation, a medium for rebuilding trust, and a pathway for restoring autonomy. Just as communities may heal from colonization through the reclamation of food systems, survivors heal through reclaiming their internal systems: hunger, fullness, digestion, rhythm, and identity. Decolonization is to land what MNT is to the body, a restoration after violation. We already have the science, the clinical models, and the theoretical frameworks. What remains is the willingness to act, to build policies and care systems that acknowledge food as a legitimate tool of recovery. Trauma may alter how the body speaks, but with the right support, survivors can learn to listen again. And in that listening, healing begins.